Good evening, everyone. My name is Barbara Goodman, and I'm President and CEO of Cures Within Reach. We're thrilled to have you here at CureAccelerator Live for Chicago. Cures Within Reach is a not-for-profit that finds and funds repurposing projects that take advantage of the speed and cost effectiveness that repurposing provides. We are patient-focused. We support both commercial value and philanthropic value projects. We're disease agnostic, we're geography agnostic, and we're institution agnostic. Cures Within Reach focuses on funding those projects that are at the critical stages of development. We love to fund projects that are at the comeback when stage, when it is proof of concept, clinical, pivotal trial data that leads to follow-on funding, that leads to publication, and leads to patient impact first and foremost. We currently have 20 ongoing clinical trial projects and preclinical projects at 17 different institutions in 15 different diseases. 40% are in the rare disease space, 25% are in oncology. We have 25% in neurology, including both neurodegenerative and mental health diseases. These projects range from adults to pediatrics, mostly clinical with a little bit of preclinical. We have projects in the United States as well as in Europe and in Australia. Most of our projects are in drugs and pharmaceuticals, but we also work in devices, diagnostics, and combination products. You'll notice on this slide that only 2 of our 20 projects are based here in the Chicago region, where we are actually based as well. Tonight, with our funding partner, the Searle Funds at the Chicago Community Trust, we're here to change that, to increase projects here in Chicago that reflect the opportunity that the biomedical ecosystem here in Chicago bring. We're so grateful for the Searle Funds at the Chicago Community Trust, our funding partner, and we're also grateful for our additional Chicago repurposing community members that are listed here on this slide. Tonight's program will be fast, but it's going to be fun as well. Immediately following this short introduction, we're going to have 8-minute pre-recorded videos from our 4 finalists. Followed by that, we'll have 4 to 5 minutes of Q&A from expert panelists that you'll hear from live. And then we'll open it up for networking and voting, where you, the attendee, get a chance to vote for who you think should get the $50,000 research grant. During the voting session, you have an opportunity to chat and ask questions with each of the finalists as well during that period. Voting will be open from about 6:15 to about 6:30 Central Time this evening. And we do ask that you, the attendee, think about the following considerations when deciding who should get your vote. Listed here: patient impact, probability of success, speed to reaching the patient, assessment of the team, and finally, the overall project. I'm now going to hand it off to my colleague, Claire Thibodeau, who's going to moderate the event and the competition itself. Claire?
Thanks, Barbara. So before we get started, I just want to take a moment and introduce you all to our fantastic panel of experts who's here with us tonight. They will be seen later on. You'll be hearing from them later on, but right now, I'd just like to briefly introduce them. We have with us Christina Alikmetz from Takeda Pharmaceuticals, Denise Angst from Advocate Healthcare, Tom Kapfer from Roundtable Healthcare Partners, Steve Crone from the University of Chicago, and Heather Stone from the US FDA. And I expect they're going to give you a lot of extra things to think about as you think about your voting considerations that Barbara mentioned. And of course, it would not be CureAccelerator Live without our finalists. And tonight we have a really strong group. They represent 4 different Chicagoland institutions, and they'll be talking about 4 different disease areas. We have Andre Lindsay from the Hines VA Hospital, Sadia Khan from Northwestern Medicine, Margaret Leota from Loyola University Medical Center, and Richard Lieber from Shirley Ryan Ability Lab. So that's enough from us. I think that it's time for us to get started and get these pitches going. The first that we have is Andre Lindsay and his project on brain injury.
Hi, thank you all for coming. My name is Andre Lindsay. I'm an Associate Health Fellow at the Edward Himes Jr. Veterans Affairs Hospital. And today I'm going to talk to you about a population that everyone here is familiar with, that everyone here knows, but a population that you likely don't routinely discuss. Today we're going to talk about disorder of consciousness. And when I talk about disorder of consciousness, when I talk about DOC, typically the first image that comes to mind is an individual in a coma. Because when we're talking about disorder of consciousness, we're talking about a change in cognitive state. When we talk about DOC, we're talking about a population that is not continuously displaying cognitive behavioral function. We're talking about a population that is solely dependent on caregivers, on family members, and healthcare providers to help maintain their medical stability, but also to advocate on their behalf. And DOC is a growing problem. There are roughly 27,000 new cases of DOC each year. DOC is frequently the result of a traumatic brain injury, or TBI, and we know that the number of TBIs has been on the rise. Between the years 2006 and 2014, there was roughly a 53% increase in the number of traumatic brain injuries. With respect to our military personnel, we know that TBI is higher among servicemen and women, and that between the years 2000 and 2017, there were roughly 350,000 traumatic brain injuries sustained by U.S. servicemen and women. And though most traumatic brain injuries won't result in a disorder of consciousness, and many won't result in a loss of consciousness, for those that do, this results in a substantial shift in life that not only impacts that individual, but also substantially impacts their family members and loved ones. And that, coupled with the growing number of cases, is a reason to further examine it. When we talk about treatments for this population, when we talk about assessments, we're talking about medical stability. Assessments look at baseline cognitive functioning, and treatments target preventing injuries from getting worse, reducing swelling, reducing bleeding, reducing pressure, preventing anything that can cause medical decline. Oftentimes, we see high inpatient care costs. Worldwide, they range between $2,000 and $400,000 in inpatient care, and with a mean of roughly $88,000. And this doesn't take into account lost wages. This doesn't take into account outpatient care. This doesn't take into account all the other changes that occur with a massive medical incident. Currently, with respect to treatment, Dr. Teresa Pape at the Edward Himes Jr. VA is looking at repetitive transcranial magnetic stimulation. Our lab has been really focused on how this can be a potential tool to aid neurobehavioral functioning, and using magnetic pulses as a means of potentiating a neural environment that is responsive to change that may aid recovery. With respect to the proposed assessment, we are intending to incorporate EEG as a tool to measure neurological changes in response to treatment, so in response to the use of repetitive transcranial magnetic stimulation, and to assess the likelihood of recovery. And this is based on a growing body of evidence that EEG, specifically evoked response potentials, can be predictive of recovery in the DOC population. And so an example of that is hearing one's own name can result in a positive waveform at roughly 300 milliseconds. So Amber, Ashley, Jacob, Michael, David, and if your name is David, you hear that, and we expect to see a positive waveform, a robust positive waveform at roughly 300 milliseconds. And for individuals with a state of DOC, this waveform is frequently present in those individuals who are likely to recover. So there's a growing body of evidence to show that, but this is mainly being used in a research setting, and the goal is, why can't this be used in a clinical setting? Like, the goal is to change that. And so really repurposing that and modifying that into a clinical assessment that's openly available. So looking at response to one's own name, but also looking a little bit past that and saying, let's look at a higher level cognitive task. So let's look at response to syntactic errors, or let's look at syntactic incongruity, which is a P600, so a positive waveform occurring at roughly 600 milliseconds, and creating a standard template that can be used for both researchers as well as healthcare providers to assess function. And so again, this is going to be part of an ongoing clinical trial. And what we want to do is establish neurotypical data, establish that prototypical response that you would expect to see, looking at individuals of different age ranges, of different sex, and as well as looking at that within individuals who have a DOC, and again, fine-tuning that predictability response, seeing if we can get that, how well that response is predictive of recovery, and matching what we're seeing in the literature. And that's going to be really where the budget targets. Getting that neurotypical response and matching the neural response with the time lock stimulus. And this work is currently funded by a congressionally directed grant. And with the additional funds to really further examine the use of EEG as a clinical assessment, whereas the current funds are really targeting that use of repetitive transcranial magnetic stimulation as a treatment tool. Our team is comprised of myself. I am a postdoctoral researcher, as well as Sherry Livingood, who is an auditory neuroscientist who focuses heavily in neuroimaging techniques, and Teresa Pape, who is a clinical neuroscientist who specializes in disorder of consciousness. So myself, Dr. Livingood, and Dr. Pape will really spearhead this endeavor. And the overall impact is to aid patient care decisions. We really want to provide researchers and clinicians with more insight regarding the use of EEG, ERPs as an indicator of cognitive function, as well as looking at potential for recovery. And to make this more openly available, because again, right now it's primarily a research tool and not really a clinical, or at least not really a clinically used tool. And it's one that has a lot of variability. And I think if there was an open standard access tool, more individuals would be willing to use it. And so with this population, it does take time to grow the sample size, but having a more standardized template will really aid the number of individuals who have access to it, allowing for better care decisions, allowing for families to really plan for what their next step should be, allowing for a better idea of long-term recovery. So thank you all for coming. Thank you all for listening. And I look forward to your questions.
One.
Thanks, Andre. You know, what I really like about your project is that it can give a kind of voice to patients who have brain injuries when they're unable to use their actual voice. And not only might your project help these patients, but they can really bring relief to family members and caregivers during a really stressful time. So now I'd like to turn it over to our expert panelists. Heather, why don't you start us off with the first question?
Hi, Claire. Thanks for having me participate. So, Andre, I thought you had a really interesting proposal. Can you describe sort of the bigger picture? What is it that you hope to achieve with this? And what would the long-term implications be for your research that this grant would help to provide funding for?
So I think the big picture is insight. We have a population that at times we're still really struggling with respect to insight and what to do next and where they are currently. And in using a physiological tool, the goal is to increase that insight. The goal is to have a more reliable measure of predictability so that families, so that caregivers, so that medical staff can plan ahead. And it's a work in progress, but the goal is to increase that insight rather than a more of a wait and see, to allow families to plan ahead.
Great, thank you. Steve, do you have a question for Andre?
Hey, Andre. So most sort of classic neuropsych evaluations are sort of multi-test, multi-point, and lead to a scoring, whether a baby is doing well, whether an adult is doing well. And it seems to me that this is a wonderful way to have an automated scoring system with a series of stimuli, a series of expected outcomes. You gave two really good examples. Can you imagine how this could be turned into an automated system that doesn't need expert supervision?
Yes, so that's a really good question. So, and the ideal would be to have sort of an automated program in which you maybe have a family member record a patient's name and then add that to a already set list of stimuli and play that, and then see whether or not it produces that ideal P300 waveform, or as we also propose to look at the P6, and have a threshold set where if you have a production of a waveform and then maybe have that waveform be of a certain amplitude or a certain size, that may be indicative of a certain level of cognitive functioning at that time, and predictive of long-term recovery. And I think with the proposed project, we're focusing heavily on just a step further establishing the P300 of the predictor, but getting it in a template where it can be used more routinely in care. But I think as a long-term goal, that would be it. Currently the way EEG is set up, particularly with these ERP tasks, is you have automated pipelines, but there's still a level of research involvement with the analysis and identifying the waveform and extracting the waveform. But even that is a big jump from where research was, say, 20 years ago. And so given that trajectory, I could see that being a possibility.
Excellent, thank you. Christina, do you have a quick question for Andre?
Andre, firstly, thank you for a very interesting presentation, fascinating project. Could you please elaborate a little? I'm assuming these measurements are going to be highly variable between different patients and also from measurement to measurement. So could you please tell us a little, what are your considerations about the number of patients you would need to study to be able to draw conclusions?
That's a very good question. So this is a difficult population to recruit with DOC, and ideally to achieve substantial power, we would like to recruit a higher end number of subjects. And additionally, important to that is also auditory stability. So following severe brain injury, depending on what precipitated that injury, you can have substantial hearing loss, which will affect the outcomes, and that needs to be accounted for in the analysis. One of the ways we try to help with that is increasing the number of stimuli to ensure that we're getting a reliable response, and doing multiple baseline assessments to better ensure the stability of that response. But it is a longitudinal study in the sense that you do have to monitor the patient over time to see both the immediate results. Maybe they elicit that P300, maybe they don't, but also looking at the change over time to ensure that it was actually predictive. And subject recruitment is a hurdle to that, but not an impossibility. It just is something that takes time.
Thank you, Andre. I'm sorry to cut you off, but we have reached our 5 minutes. So thank you very much.
Thank you.
We will be moving on now to our next presenter, Sadia Khan, and her project in heart failure.
Good evening. Thank you to Cures Within Reach, our expert panelists, and everyone in the audience for the opportunity to share our proposal. My name is Sadia Khan. I'm a heart failure doctor and clinical researcher, and every day I care for people living with heart failure with preserved ejection fraction. the most common type of heart failure today. I'm going to begin with a short video of 2 of our patients who are just in the hospital, and like 13 million people worldwide are struggling with heart failure with preserved ejection fraction.
And doctor told me he said again, my heart beats fine, pumps fine. It still has strength, but it is stiff.
Walks or something was difficult, but I felt major effort scared. I felt scared that my life was coming to an end.
As you heard firsthand, the debilitating effects of heart failure with preserved ejection fraction, or HFpEF, can be quite significant. As our first patient explained, HFpEF results from a stiffening of the heart muscle with a preserved pumping function. However, the stiffening leads to fluid backing up in the body and fluid retention, which can lead to symptoms of breathlessness, hospitalization, and poor health-related quality of life, similar to patients with advanced cancer. HFpEF significantly affects physical, psychological, and social well-being, understandably leading to questions about prognosis and associated fear, as relayed by our second patient. Now, hospitalization in HFpEF is really the sentinel event for decline. In the United States, 500,000 people are hospitalized every year with HFpEF. Of these, 1 in 4 will be hospitalized again within 30 days. 3 in 10 will die within 1 year of hospitalization. Now, these numbers are dire and shocking, but they are even worse for those patients with HFpEF who also have chronic kidney disease. This is because of the heart-kidney connection. More than 2 million people worldwide have HFpEF and chronic kidney disease. Because the heart and kidney are supposed to work together to maintain fluid balance in our body, impairment in the heart from stiffening and impairment in the kidney function leads to exceedingly difficulty in managing fluid balance. As a result, higher rates of fluid retention, congestion, lead to poorer outcomes in those with HFpEF and chronic kidney disease. Yet these patients are often underrepresented or excluded completely from HFpEF clinical trials. As a result, the current treatment approach is inadequate. Because these patients are vulnerable to fluid retention and that fluid balance is difficult to manage, they are more likely to be receiving higher and higher doses of diuretics, multiple diuretic pills that can be difficult to manage, difficult to remember all of the doses and times from which to take the medicine, and lead to side effects, ultimately leading to worsening kidney failure and hospitalization. In aggregate, heart failure accounts for $30 billion in healthcare spending every year. While the investigational landscape for new molecular therapies targeting the heart in HFpEF is quite exciting, as shown here, these may not be what's best for this vulnerable population with HFpEF and chronic kidney disease. Specifically, we are proposing a new approach that targets the kidney by repurposing these 3 drugs shown here that I'll explain more in the next slide into 1 pill, a polydiuretic. Now, this polypill approach is very well established in other chronic disease states like high blood pressure and HIV, where it has been demonstrated to be more effective, safer, and easier for patients to take, but it's never been tried before in HFpEF. Shown here is a kidney schematic that shows the 3 components of the polydiuretic and where they act in the kidney: the sodium glucose cotransporter 2 inhibitor, the loop diuretic, and the aldosterone antagonist can work synergistically together, allowing lower doses in 1 combination pill to be safer and more effective. While this concept sounds deceptively simple, without the bridge funding from Cures Within Reach, this study will not be possible. Shown here is our timeline, including our IND exemption that we've already filed for and received from the FDA, our IRB submission that we anticipate approval for in the next few weeks. We expect that recruitment will take approximately 6 months, and by spring to summer of 2021, we will have completed data analysis and publication of our primary results for wide dissemination. This will position us well to begin multi-center trials to enhance the generalizability of our study. I'm extremely grateful for the in-kind effort and research dollars from Northwestern Medicine to cover personnel costs for the team that have allowed us to reach this critical juncture to be seeking your support today. Specifically, we are seeking funding for data management and coordination, medication cost and over-encapsulation, and a research coordinator, without which this study will not be possible. Shown here is our incredible multidisciplinary team with expertise in implementation science, clinical trial design, chronic kidney disease, and biostatistics. In addition, our trial will be supported by the Bloom Cardiovascular Institute that has coordinated more than a dozen HFpEF clinical trials. Shown here are our future directions, whereby results from this pilot study will allow us to secure the next round of funding for multi-center trials. We will leverage our existing collaborations with international organizations like the George Institute that already have commercialization pipelines in place that they are using currently for a high blood pressure polypill with Dr. Huffman, one of our team members, that will allow us to accelerate the timeline. We anticipate cost savings in excess of $3 billion based on a 10% reduction in hospitalization. In summary, I hope I've convinced you that a polydiuretic compared with the current approach or new molecular therapies is superior because of the cost saving potential. It will be safe and well tolerated. It will improve care and outcomes of our patients and will be easier to administer in one pill. With your support today, we look forward to changing the paradigm from one of heart failure to heart success. Thank you for your time and attention. I'd be happy to take any questions at this time.
Thank you, Sadia. You know, when I first read this project, I was really struck by how simple and elegant the polypill is. Combining all 3 drugs seems obvious when you think about it, and this team took that simple idea and really improved it. So to start the panel, I'm going to ask Christina for the first question.
Thank you, Sadia. Thank you for the excellent presentation and this fascinating idea. The patients you're talking about, patients with heart failure, I don't know if the audience is aware, but this is a condition that carries a very bad prognosis, and therefore treatment and success of therapy is crucially important to improve the lives of these patients and prolong their lives. So the medications that are used for majority of heart failure patients do not necessarily work in this particular group of heart failure patients. Diuretics do work. In your study, you're combining 3 different types of diuretics. So my question is, how would you ensure that it is not too much of a good thing, that you would not overdo the effect of a diuretic therapy, because those patients, on the other hand, are dependent on getting enough volume to pump?
Wonderful. Thank you for that really important question, and something that we've spent a lot of time thinking about. One of the ideas behind the poly pill and ensuring that we are getting an effective dose but a safe dose is by using half the regular or recommended dose. So the combination starts off at a far lower dose of each pill than is typically recommended. And we've actually been able to do some investigations and clinical trials of heart failure patients that are already on 2 of these combination therapies in different combinations and have found that it's safe. We really need this data to be able to show that it's not only safe, but could be effective in this manner.
Thank you.
Great. So Denise, why don't you take the second question here?
Sure. Again, thank you for your attention to this important area. We certainly see a rise in incidence of prevalence of this in our large health system. It appears to me that patients are currently being treated with these therapies separately in heart failure. So, what do you expect as the unique or enhanced benefits from their simultaneous administration in terms of efficacy? You talked a little bit about toxicity, but also cost.
Absolutely. Thank you for that really important question. One of the critical issues in managing heart failure care is clinical inertia, and the second is adherence. Even though we know that all three of these medicines are effective and helpful in reducing hospitalization, we know from national registry data from the American Heart Association that less than 15% of patients for whom an eplerenone or another medicine of that category, one of the three in the combination, are actually receiving that medication. Further, we know that at least 1 in 5 individuals who are ending up in the hospital is due to a lack of adherence, given the significant pill burden that these patients face, especially as they get older and have other chronic conditions as well. So those are two critical problems that we hope that this polypill approach can solve and has been successful in other conditions like HIV.
Thank you.
Thank you. Heather, how about a question from you?
Dr. Khan, I really appreciated your presentation. And as you say, this has been an approach that has worked well in other conditions like blood pressure. Can you talk about whether you'd be able to use a single dose of each drug and therefore enabling a fixed dose combination pill, or whether you're anticipating that multiple dosing options would be required for different patients?
Thank you for that really important question. I think we all know that personalizing care and this shift towards precision and personalized medicine is really an important aspect of how we want to contextualize this polypill. This would really be a foundation, and so would allow us to begin with the lowest starting dose, and we could consider other poly combinations in the pipeline, multiple doses, as well as other step-on therapies from different components of it. So I think absolutely we're going to need to adjust and personalize as we move forward, but we know that most people aren't getting even the foundational amount of each of these components yet.
Great. Thank you, Sonia. All right, next up we have Margaret Leota and her project on ovarian cancer.
Good evening. My name is Margaret Leota, and I'm a gynecologic oncologist at Loyola University Medical Center. I thank you for the opportunity to present our proposal for repurposing a blood pressure drug for recurrent ovarian cancer. It whispers, so listen, is a phrase often used in reference to ovarian cancer. It is in reference to a disease that has subtle symptoms, and as a consequence of this, women delay their care and are diagnosed in stage 3 or 4 disease. Ovarian cancer is the deadliest of gynecologic cancers, with over 22,000 new cases and 14,000 deaths estimated in 2020. Although initial treatment responses are good, there are several challenges with this disease. There is a poor 5-year survival rate. For patients with advanced disease, the survival rate is only 30%. We also have a high recurrence rate, with approximately 70% of women having a recurrence. This is the most frustrating part of the disease because patients do not stay in remission for very long. And once recurrence happens, we are constantly fighting the disease with treatment with poor response rates. Patients can have multiple recurrences in their lifetime before succumbing to ovarian cancer, and we still have yet to find a treatment that gives us a lasting response. Patients can also develop resistance to chemotherapy drugs, and recurrent cancer is rarely a curable disease. What is needed is a treatment that kills cells in a novel way. We need new options to give hope and quality of life to our patients. We propose an inexpensive oral medication that is already FDA approved for the treatment of hypertension called minoxidil. We are targeting platinum-resistant recurrent ovarian cancer patients. There are several benefits of this new therapy, including ease of administration with an oral route. It's cost-effective with a 10 milligram tablet costing approximately 37 cents. There's no effect on blood counts, which can be a problem in patients who have had multiple chemotherapies. And there is no hair loss, and in fact, this may promote hair growth. Our previous studies have shown that minoxidil arrests tumor growth in a mouse model through stimulation of a potassium ion channel that is specifically expressed in tumor cells. And these channels have been shown to be expressed in ovarian cancer cells. Our basic science research shows evidence to this. We used a mouse model where we injected ovarian cancer cells intraperitoneally. We then treated the mice with placebo versus minoxidil. These are the necropsy photos after the treatment has been completed. As we can see, the tumor burden, which is outlined in red, is still extensive in the mice that were treated with the placebo. In comparison, the mice treated with minoxidil had complete response with no visible disease, and in 3 of the mice, and the 4th mouse has a very small amount of disease. This bottom panel also shows the effectiveness of minoxidil through a COMET assay. The COMET assay demonstrates DNA damage, and the extent of damage is noted by the length of the tail. In this lower panel, we can see that minoxidil produces extensive DNA damage, which also supports our theory that this will help in ovarian cancer patients. Our primary objective will be to evaluate the response rate of minoxidil in patients with platinum-resistant ovarian cancer. Our historical response rates are 10 to 15%, with our expected response rate to be about 25% for it to be clinically significant. Our secondary objective will be to describe the toxicity profile of minoxidil. We plan to enroll up to 31 patients to evaluate the efficacy as measured by comparing imaging studies. Our initial starting dose of minoxidil will be 5 milligrams, and this will escalate daily as tolerated by blood pressure measurements. These will be monitored daily. Our baseline laboratories and physical exam will be done monthly, and imaging studies will be done every 2 months. This is a chart showing our Simon 2-stage min-max design, where patients will be enrolled in 2 stages. Initially, we will recruit 16 patients, and this will be done to invoke the early stopping rule. So we do not proceed with the remainder of the study if less than 25% response is seen, which we have deemed not clinically significant. So how will we accomplish this with the $50,000 budget? The majority of our budget will be towards a clinical research nurse for data collection and patient recruitment. We also will have additional funding for a postdoctoral fellow through an endowment fund. This project will have the collaboration of a strong investigative team that brings years of clinical and basic science experience. Along with myself, Dr. Pockel has extensive clinical trial experience and is also the OBGYN chair at Loyola University Medical Center. Dr. Dansu also has extensive clinical trial experience and in fact is the director for Cancer Center Clinical Trials at the University of Illinois. And Dr. Gentile has had many years of experience investigating ion channels in cancer, and his basic science research is the basis for our current proposed study. Our accrual will be robust with collaboration of 2 Chicagoland academic centers and should be feasible within our proposed 24-month time span. In summary, this is a project that looks to provide us with a new treatment for recurrent ovarian cancer that will help extend quality and quantity of life for patients. It is a convenient regimen that is inexpensive. We have a quick timeline, and the fact that this drug is FDA approved will make this easier to get to patients faster. Our mouse model supports feasibility and mechanism of action for the drug. And again, our qualified team is ready to execute this study in a timely manner. If found to be effective, this will bring a much needed new drug to the armamentarium in the fight against recurrent ovarian cancer. I thank you for your time and welcome your questions.
Thanks, Margaret. You know, you were really right when you said that ovarian cancer whispers. And, you know, even when women see symptoms, ovarian cancer is not always the first diagnosis that comes to mind. This trial clearly addresses an unmet need for women who need treatments using an inexpensive generic drug, which I think is pretty neat. So, Tom, we haven't heard from you. Why don't you ask the first question of Margaret?
Okay, Claire, thank you. Dr. Leota, excellent presentation. Very much appreciated. My question is, if your research is successful, maybe better said, when it is successful, this repurposed drug could lead to an inexpensive treatment for ovarian cancer patients who are resistant to chemotherapy. So could minoxidil also be used to treat ovarian cancer patients early to potentially reduce or eliminate the amount of chemotherapies that are needed post-surgery before cancer reoccurrence or chemoresistance is seen?
Well, we currently have 2 drugs that work very well. Like I stated earlier, there's an 80% success rate with those drugs. I think we would have to have a phase 3 trial looking at that to be willing to start with minoxidil versus something like that. That could be in the future, but I think we'd have to see what the results are with this study to start with.
Thank you.
Mm-hmm. Steve, do you have a question for Margaret?
Yeah, I'm sort of a super fan of repurposing, and minoxidil has already been repurposed, of course, as Rogaine, so it would be like an extra super special. So I have a double question.
Okay.
First is the target of minoxidil as expressed in these cancer cells is well defined, and only a subset of these patients express it. Are you going to select patients based on their potassium channel expression, or why not? And then the second part, B, is these approaches as one-off, as single drugs are often, in these kinds of cancer trials, are often a disappointment at this phase, whereas when they're combined into conventional therapy, they're often successful enough that you can see a statistical signal. Given that the patients who are called platinum resistant are often still given chemotherapies as a maintenance therapy or palliative therapy, wouldn't it be effective to add that in and hope to see a big signal there?
To answer your first question, we really would like to just try to recruit the patients initially, and we will be looking at the patient's tissue to see whether they have expression to that receptor. We did entertain the idea of selecting those patients, but we would like to just try to do that initially at the first go round. And to answer your second question, as far as adding a chemotherapy, that was also discussed because we do have some preliminary data that perhaps minoxidil actually overcomes the platinum resistance in some of these patients. So that could be a future project should we see some improvement with this project initially.
Great. We have time for one more quick question. Christina, do you have a quick question?
Thank you. A quick question about the dosing. You're starting with a pretty low dose. What is your plan in terms of increasing doses? Because for cancer patients, usually we always try to go to the maximum tolerated dose.
Correct. We will be starting with that first initial 5 milligram dose and doubling that daily as long as we see blood pressure hold up for those patients. We just don't want to cause hypotension. In our mouse model trials, the dose that seemed to be the most effective was about 50 milligrams. So it's not near the maximum dose even in the FDA insert. So that will also be a part of our project, is trying to identify the optimal dose.
Thank you.
Excellent. Thank you very much. And now, last but not least, we have Richard Lieber and his project in cerebral palsy.
Good evening. Thank you for letting me share my project with you entitled Repurposing a Cancer Drug to Treat Muscle Contractures in Cerebral Palsy. My name is Rick Lieber. I'm the Chief Scientific Officer at the Shirley Ryan Ability Lab and professor at Northwestern University. Cerebral palsy is a debilitating disorder. It's the most common movement disorder in children, and about 6,000 babies per year are born with CP, which is about 5 times the number who are born with Duchenne muscular dystrophy, which more people have heard of. CP affects about 17 million people in the world, and therefore has a tremendous prevalence. Muscle contractures affect about 1/3 of the people who have cerebral palsy, and the incidence is growing. This is because the neonatal intensive care units are getting better at keeping younger babies alive, and more premature babies are being born. But unfortunately, many treatments are only available in the highly developed or wealthy regions of the world. Muscle contractures in cerebral palsy are common. They result in loss of movement, decrease in strength, and pain, and limit the child's ability to interact with friends, play, take the bus, etc. There's little progress that's been made recently, primarily because there is no animal model of cerebral palsy, and there's little financial support for CP research, unlike, for example, Duchenne muscular dystrophy, where drug companies and startup companies will get involved in drug development. And as a result, the current approaches are insufficient. Treatments are largely based on traditional conservative therapies, such as splinting, casting, and orthotics, or strengthening and stretching therapy, or even Botox and baclofen medications that decrease the excitability of muscles and the spinal cord. When all of these fail, and they often do, surgery is indicated. And as you see in the picture in the upper right, this is a child who's had his adductor muscles, which bring the legs together. The adductor muscles have been cut and resutured at a longer length, and now he'll be immobilized in this position for 4 to 6 weeks while the muscles heal in their new position. So the treatment is kind of agony. The kids take a lot of abuse over their lifetime, especially during their young years, and it's really a Band-Aid, not a treatment. Our hypothesis is that the treatments don't work very well because the muscles are unable to biologically respond to these current treatments. And so we've come up with a novel treatment of muscle contractures, and it's based on the following logic. Since muscle stem cells are required for growth, and CP muscle does not grow either in length or in width, we measured the stem cell properties of CP muscle obtained during surgery, and we made 2 discoveries. First, we found that these kids have lost about 80% of their stem cells. And as you might imagine, stem cells that are required for growth and adaptation and repair, if they're gone, that's bad news for the tissue. Secondly, the stem cells that were remaining were hypermethylated. This is an epigenetic construct on top of the already present loss in stem cells. What it means is this hypermethylation results in a cell type that just grows and grows and grows, but doesn't turn into muscle. So the stem cells they have left don't even turn into muscle. That's bad news. But it sounds sort of like another disease, doesn't it? The hypermethylation, the hyperproliferation sounds sort of like cancer. And so we screened cancer drugs and found that a demethylating agent known as 5-azacitidine, or I'll refer to it as AZA, actually restored the CP stem cells to normal. So when we treated the cells with AZA, they turned into muscle, which was cool. And you can see the data on the right-hand side show in the open bar above the CP group, the CP muscles are hypermethylated. We treat with AZA, and that methylation level is brought back down to normal. So now we've got a provocative idea that perhaps we can have a non-surgical treatment that will biologically enable all these other therapies. So in order to do that, our next step is a dose escalation study, as shown here. We've completed the study that shows that azacitidine rescues CP muscle stem cells. And now, for the next year, we'd like to do a dose escalation study ranging from 10 to 30 milligrams per square meter over the period prior to surgery and see if we can fix the muscle. By the way, 10 to 30 milligrams per square meter is between a third and a tenth of the normal therapeutic dose, which probably indicates that it will be safe. In the future, these data will allow us to apply for federal funding for an AZA clinical trial. Now here's the time course. In 15 patients already scheduled for surgery, so there's no novel surgery here, patients already scheduled for surgery will have a blood draw, a time course of azacitidine treatment, another blood draw, surgery on day 15, and then 2 more blood draws. At each visit, we'll do a physical exam, complete blood count, liver enzyme tests so we can determine the kinetics of the drug as well as any potential toxicity. And then we'll get the muscle biopsy so we can see, did we fix the stem cells? The great news of this project is we only need $50,000 to do it. And the reason is twofold. One, we've got a team underway. There's no recruitment we're going to have to undergo. Number two, we've got in-kind support and intellectual support from Celgene, who makes the drug. And number three, we've got a lot of institutional support at the Shirley Ryan Ability Lab. This $50,000 will allow us to get to the next step, and there are no other funds available to do this study. Our team is great. Myself and Andy Domeneghetti, we're muscle scientists at the Shirley Ryan Ability Lab. We live every day with the patients, so even though we're scientists, we know what these clinical problems are like. John Cunningham is the chair of pediatrics at the University of Chicago and a pediatric oncologist. John has been using this drug to treat kids with cancer now for about 30 years, and he's the one who advised us on the dosing. Masha Kochaginski is a biostatistics professor at Northwestern. She's the one who told us that there was probably about 15 kids needed to adequately power this study statistically. So in closing, I'd like to remind you the study will establish a new paradigm for non-surgical treatment of muscle contracture by biologically enabling muscles by azacitidine treatment. The great thing about this is we might save millions of dollars over the lifetime of that child. We're confident that our successful in vitro muscle experiment will result in a successful dose escalation trial that will change the stem cells themselves, and we can complete the study in 12 months based on our current clinical loads. We have an outstanding multidisciplinary team in place, and what's more, this repurposing approach might actually even work on contractures from other upper motor neuron lesions, such as spinal cord injury, stroke, and head injury, and that will just dramatically escalate the impact of this work across the country. Thanks very much for your attention. Good evening.
Thanks, Richard. You know, it's really amazing to me how cancer drugs are being repurposed in so many diseases these days, from Alzheimer's disease to immune disorders to rare diseases. Your project brings together a team of experts from different disciplines and perspectives to make an impact for pediatric patients. So why don't we start with Denise? Do you have a question for Richard?
Sure. Well, first, Dr. Lieber, thank you for your novel work in this area. As a pediatric nurse, which is my background, I've certainly seen this as a significant complication in CP that has physical and psychosocial consequences. My question really is around the dosing. My understanding in pediatric cancer, the dose is close to about 75 milligrams per meter squared. You're going with 10 to 30. And so my question is, how have you determined that that's going to be a sufficient enough dose to cause, you know, the demethylation and the restoring the function of the human muscle cells?
Yeah, it's a great question. That's a big unknown. So we have been working with the manufacturer. They've obviously done a lot of in vitro and in vivo stuff. So we have very high resolution in vitro data where we look at dosing of azacitidine relative to demethylation in human cells in vitro. And we've basically extrapolated using the same formula that the manufacturer has used to extrapolate to humans. But the cool thing about the design of the study is because it's a dose escalation study, and as you say, the typical clinical dose is 75 milligrams per square meter, we can go 10, 20, 30. And if we see nothing, we'll go 40, 50, 60. And Dr. Cunningham believes that it's ethical to even go up into the hundreds for shorter periods of time. So this has the the dosing protocol has a feedback loop where we're going to be looking at the actual muscle. If we don't get an effect, we will keep escalating. But we estimate 10, 20, 30 to be the right range.
Gotcha. Thank you.
It's a good question.
Tom, how about you?
Yes, Dr. Lieber, AZA is a drug that's been around for many years. But how much would treatment with AZA cost cerebral palsy patients, and what kind of reduction in healthcare costs, the reduction of the surgical and other interventional procedures, what ultimately might be saved from a cost perspective if this is successful?
A great point. So it's obviously it varies by patient, but let's say a course of azacitidine is several $1,000s, $3,000 to $7,000. Surgeries, for example, for contractures, depending again on exactly what's done, are maybe $10,000 to $40,000. And importantly, they're repetitive. Surgeries and contractures tend to happen once or twice during the child's life, during growth spurts, et cetera. So the direct medical costs of contracture treatment are probably in the hundreds of thousands of dollars. Lifetime treatments related to contracture, loss of function, et cetera, are estimated at $1 million per child. So if you could really prevent contractures, and that's why I'm so excited, if you could actually go to the biological basis of why the contracture is happening in the first place, we think all kinds of things would happen. We have no data on speech and swallowing, but that's also a big problem in this patient population. We've been focusing on hand and leg function, but we're really excited about the possibility of literally curing the muscle of its fundamental defect and avoiding a lot of these secondary kind of palliative Band-Aid procedures.
Thank you.
Heather, you get our last question of the evening. Take it away.
Lucky me. Interesting proposal, Dr. Lieber. You said that the drug would demethylate the stem cells that remain, but if I understood correctly, it wouldn't overcome the problem of the fact that 80% of the CP patient's stem cells are missing, would it?
No, that's an excellent point. So the question of why they're losing their stem cells in the first place is a big one. Our hypothesis is that this hyperproliferative phenotype where the cells just grow and grow and grow, burn out the stem cells. So we think that the reason there's only 20% of the stem cells left is because the other ones have become extinct, essentially. So an early treatment with azacitidine, we think would allow the stem cell niche to remain populated and that the loss actually won't occur. Now, if let's say later in the child's life, the loss did occur, stem cells are smart. It's just amazing what they do. We think that they actually may be able to repopulate the stem cell niche because they can sense what's going on in the niche, and when it's empty, they actually send more cells into the quiescent phenotype. So those are really important questions and are challenging because there is no animal model, but that's at least our thinking now. But it's a really good question.
Thank you.
Excellent. All right. Well, that concludes our pitch and Q&A session for the evening. Thank you all to our panelists and our finalists who worked so hard to get here, and our panelists who put together such great questions tonight. A virtual round of applause for all of you. And now is the time where we turn it over to the attendees. And I know this is going to be a tough decision. It's going to be a tough decision for me, that's for sure. But attendees, it is now time to vote. Because of the magic of virtual events, we're running a little ahead of schedule. We're going to open the voting as soon as we're done here. We're going to close the voting at 6:20, and then we will announce the winner at 6:30. So be sure to get your votes in by 6:20 tonight. So again, please keep in mind the following considerations as you're thinking about each of these projects: patient impact, probability of success, speed to patient, assessment of the research team, and then again, the overall project. And for all of you that have questions for our finalists tonight, who didn't get a chance to ask yet, great news. You can interact with each of them in their very own chat rooms. Simply click on the button that you see that says finalists, and you can navigate to their chat rooms through that. They'll be available until voting closes to answer any questions, chat a little bit more about their projects. So don't be shy. They'd love to talk to you. Once again, we have Andre Lindsay from the Hines VA Hospital with his project in brain injury, Sadia Khan from Northwestern Medicine with her project in heart failure, Margaret Leota from Loyola University Medical Center with her project in ovarian cancer, and Richard Lieber from the Shirley Ryan Ability Lab with his project in cerebral palsy. So with that, voting is open. Have fun, and we'll see you back at 6:30 to announce the winner.
Hello again. Welcome back. We are very excited to reach the stage of our evening where we get to announce the winner of a $50,000 research grant to one of those 4 amazing finalists. Before we get to that part though, I want to again thank our funding partner, the Searle Funds at the Chicago Community Trust, for their support not only of this research grant, of our efforts to increase the repurposing community here in Chicago. We're also very grateful for the partnership of our additional Chicago repurposing community members representing industry, philanthropy, as well as the service providers and the companies that are listed here on the slide. If you want to help us impact more patients with unmet medical needs, we would love to fund not only the winner tonight, but the 2nd place, the 3rd place, and even the 4th project. With your help, we can do just that. Feel free to donate to Cures Within Reach today to help us fund the 2nd and 3rd and 4th place projects. There's a donate button in the engagement panel. It'll take you straight to our site. In addition, feel free to contact us if you want to talk with us about how we can focus in a disease area that you're interested in, whether it's pediatrics, oncology, neurology, cardiovascular projects, could be rare diseases, it could be a geography like Chicago. We'd love to have that conversation with you. We customize our funding approach to any donor's interests in any disease area. And we'd love to work and get more projects like this funded, as well as the 2nd, 3rd, and 4th place winners tonight. Before we announce the winner, I want to remind everyone of these amazing projects from the Department of the VA and Edward Hines VA Hospital with Andre Lindsay and brain injury, Northwestern Medicine and Dr. Khan's project for heart failure, Dr. Leota's project from Loyola, looking at ovarian cancer, as well as Dr. Rick Lieber from the Shirley Ryan Ability Lab, making an impact in cerebral palsy. I'm going to hand it now to Claire, who's going to have the last word tonight.
Yeah, and again, while it's not quite the same without the giant check and without, you know, everybody standing around and getting to celebrate the winner in person, we are still very excited to announce the winner of the CureAccelerator Live for Chicago. And that winner is Richard Lieber from the Shirley Ryan Ability Lab. Congratulations.
Yay, thank you. That's great news. That's just great news.
Great. Well, we're sure that you will put this money to good use and make that patient impact.
Well, we are thrilled to partner with you guys, and we will make you proud and do a good job. And as everybody knows, the competition was stiff. So on behalf of my colleagues, Dr. Domenighetti and Dr. Cunningham, I really, really appreciate the opportunity.
Great.
Wonderful. Well,
Thank you,
congratulations to Dr. Lieber and the Shirley Ryan Ability Lab. And to the other finalists, know that our team is already hard at work, working to get others funded. We actually did this event in June and have already approved not only the first and second place, but we're working on the third place as well. So it absolutely happens, and we are hard at work raising funds to get all of these projects funded because they all deserve to be funded and make an impact in patients. With that, I want to thank everyone for joining us tonight. I want to especially thank our expert panelists who participated from many different states, and we're thrilled to have your expertise with us. I want to thank the finalists who spent a lot of time behind the scenes preparing the conversations for you. And I want to thank all of you attending virtually. It's not the same as being in person, but we're thrilled to do it anyway, and we're thrilled with the competition and really appreciate you participating. Thank you all so much. Have a wonderful evening.
Thank you. Good night, everyone.
Thank you. Good night.